Hello, everyone, and thank you for joining us for webinar 3 of the RCM EPM series. The webinar today is being recorded and will be posted to our website. We will also send the recording and slides to all participants at the end of the series. My name is Latrell Courtney, and I am the Consultation Clinic Specialist with the National Rural Health Resource Center, which is providing this webinar today. If your video feature is not connected, you can do so by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. So please remain muted unless you have a question. If you need to unmute your line, you can do so by selecting the microphone icon in the lower left corner of your screen. If you dialed in, you can unmute yourself by pressing *6 from your line. You can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. And if you haven't done so already, will you please take a moment to type your name, title, and organization in the text in the chat box so we can know who's joining us today. This helps us to get a good feel of the audience on the webinar. The National Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the nation's leading technical assistance and knowledge center in rural health. The center has served rural hospitals, clinics, and other providers nationwide for over 25 years and has partnered with the Federal Office of Rural Health Policy for nearly 25 years and collaborated with Delta Regional Authority for nearly 15 years to assist rural providers and communities with healthcare needs. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about our commitment on our website at ruralcenter.org/DEI. Okay, so we have 3 pre-polling questions that we would like you to answer before we get started on today's session. For the first question we have, I am blank in my understanding of how to compare my organization's key performance indicators, provider productivity benchmarking, and current procedure terminology code distribution to industry benchmarks. I am blank in my understanding to enhance back-end revenue cycle performance. I am blank in my understanding of best practices related to rural health clinic operations and reimbursements. So give a moment to see what the results are. Okay, so we have 10% who feel confident, 24% of you feel somewhat confident, 33% are neutral, 29% somewhat unconfident, and 5% of you are unconfident. Okay, thank you, Caleb. So today's webinar is the last of the Revenue Cycle Management series. This series does qualify for ACHE continuing education credits. If you would like to receive credit, Caleb Lazinski will be sending out an email upon the completion of this series in which you can fill out the form to receive continuing education credits. In today's session, physician practice management best practices, we will review of how to compare key performance indicators, provider productivity benchmarking, and current procedural terminology code distribution to industry benchmarks. It is my pleasure to introduce today's presenters, Steve Smith and Carson Cleveland. Steve is a member of Forvis's Healthcare Performance Advisory Services Division and Forvis's National Healthcare Group. Carson is a member of Forvis's Healthcare Performance Advisory Service Division. Steve and Carson, I'm now going to turn the presentation over to you.
Thanks, Latrell. So again, at any point, if you can't see the screen or anything, just let me know. I'm going to keep the chat box up. If you have a question, feel free to type it in the box. We may address it at the end, or If it's something related to one of the slides that we're covering, I can try to address it while we're talking about a specific topic. So I'm going to go ahead and move. So here's our contact information. Like they mentioned, you will get the presentation. So if you need our emails or our phone numbers, they're located here. This presentation, I'm not sure if they had preloaded it onto the meeting. It's going to look a little different. I tossed in a couple of slides and put in a few different metrics, but we can make sure this is the presentation that you all get access to. So like Latrell said, Carson Cleveland. I've been with Forvis for about 2 years. My background is hospital system and clinic operations. So I came from a large academic medical center, had the chance to work on and see a lot of different areas in that spectrum. And so with Forvis, I work on some rural health related activities, but more so on the physician practice management side related to the rural health activities. I'm sure some of you may recognize me if you've had the chance to go through our kind of RCM and PPM assessment. Myself and other colleagues kind of lead up the physician practice management side. And then we have colleagues that do more of the revenue cycle focus for the hospitals. So like Latrell mentioned, we're going to review a few different things today. So the first section is going to be really just related to physician practice management. So we're going to look at some KPIs, get into a little bit of provider benchmarking and EMR distributions. And then we're essentially just going to walk through the entire revenue cycle process and things that we think about when we're coming into an organization to look at a clinic or look at multiple clinics and things that we got to keep in mind as we're doing these assessments, and things that can be beneficial for you to kind of take back to your organization and implement, and questions that you can ask to try to ultimately do what's best for your organization and meet some of these goals and benchmarks that you'll see in the presentation today. And then Steve will come on and present after, and he'll focus more on the rural health side, looking at a little bit of policy, some of the updates more for the rural health perspective. So I'm going to go ahead and kind of skip over. This is just a general layout of how the presentation will go. So the first thing we're going to look at is really key performance indicators. But I added this slide in. So if you've seen the presentation before, you may not have the slide. So the goal of this slide is I would like for you to kind of keep this in mind when we go through our presentation. So a lot of you may be familiar with kind of the SMART thinking methodology. But this is definitely something that's very important when we're thinking about, hey, what goals are we going to try to implement? What metrics are we going to look at? And how exactly is that going to kind of fit into the operations of our organization? So anytime we're looking at a benchmark or something that we're going to measure, it needs to be specific. So we want to understand what exactly are we looking at? What is our goal for that specific metric? And so that kind of gives you, hey, this is specifically what we're going to be doing. And that being said, we don't want you to bring in something that's not in line with what your organization is working on. So just keep in mind, kind of in the back of your head as we're going through this, that SMART methodology. And that's kind of the focus that we have when we're coming into an organization to understand what exactly is happening in your clinic and where are some areas for opportunity for improvement. So on the left side of the screen, this seems like a lot. This is by no means all key performance indicators, but the goal here is just to kind of give you an idea of the things that we look at when we're coming into an organization. The top 4, I've included some actual metrics. So kind of looking at the denial rate, the percentage of AR, clinic charge lag, and then the point of service collections. Really the goal here is to kind of see what are we working on for our clinic? What is our priority as an organization? And then take some of these key performance indicators and actually apply those to, hey, these are things that we think will be beneficial and help us kind of drive change and track and trend over time. So that being said, by no means do you have to track every single one of these. These may be things that you're not tracking necessarily every single day, but you may be doing on a weekly, bi-weekly, monthly basis. But all things that can be beneficial to get a better understanding of where your organization is performing, but not only where you're performing related to other organizations in your community, but also kind of across the country. And then this gives you a chance, if you are tracking these metrics, to trend them over time to kind of see how are we performing? Are we improving on our goals? Are we actually getting closer to kind of some of these goals that we had set in the initial decision when we're looking at key performance indicators? These can be broken down into a lot of different areas. So some of these are more revenue cycle driven, looking truly at denial rate, percentage of AR, and then some of these are more operational. So clinic charge, like how quickly are providers getting encounters closed? Are we having issues with getting bills out in a timely manner? And so the thing I would say when you're looking at any key performance indicators, some of them will be more so a actual metric that you're trying to look at. So something like denial rate. I'll use denial as an example. So if we see that we have a denial rate, the goal here, so in green is kind of the benchmark goal for the national average. So less than 4.7%. So if we have that denial rate and we realize our denials are a little higher, it doesn't mean that we have to stop there. So you can use some of these other key performance indicators to kind of drive down a little bit deeper into why specific denials may be occurring. So if we realize that, hey, we haven't done a coding and documentation review for our providers in a while. So if it's been a couple of years, denials, if they start to creep up and they're getting a little bit higher, that may be a chance to say, hey, we need to kind of take a step back, look at our whole system, look at how we're coding and documenting, make sure that we've done kind of everything on our end from a training perspective to make sure that we've given our staff the right tools that they need to be able to take care of patients and code and document appropriately so that we're not having these back-end denials that are coming from the insurance companies. So in mind, so while you're kind of keeping these key performance indicators in mind, there's some questions that we generally try to ask when we're looking at, okay, if we have access to data in our system, are we able to dashboard some of this data? So getting it to live in one location in a uniform setting. A lot of times we go into organizations, we see that one clinic or one individual within the organization may be tracking something, but it doesn't mean that everybody has access to that report or to that data. So a lot of time, if you're spending time and effort getting a report together, looking at specific types of data and trending things every time, we want to make sure that everybody in your organization has access to all of the information that you are putting out on a dashboard, putting out in these reports that you may have on a monthly basis, or sharing in any general platform. If you have a revenue cycle meeting, who has access to that meeting? What are our topics that we're covering? Who can kind of disseminate that back to the clinics, back to these frontline staff, so that we can make sure that these things that we're talking about more at a system and strategy level, how are they impacting kind of our day-to-day operations? So the first thing to keep in mind is, what capabilities does our EHR have? Does our EHR have a good reporting system? Do we have issues with how we're capturing data? Are we having to use multiple different systems to get to a specific element within the EHR? So sometimes we see you have to use a separate reporting system, or your EHR may not have data that you are comfortable with to use to drive some of these changes, and that's completely okay. We see this pretty often, to be honest. And really the thing to keep in mind when you're looking at your EHR, is not necessarily, does it do everything that all of these other EHRs do, but really, is it meeting the needs of our organization? And if there are gaps within our EHR's capabilities, how are we addressing those, and kind of who's responsible for managing some of these items? So the next item is really, okay, our EHR does have the capability. We're capturing all the data. We have the reporting capabilities set up within the EHR, but where exactly is that data living? Sometimes the hospital is more responsible for reporting. If the billing is going more on the hospital side, and you say we have a coding and documentation team that's located more so in the hospital than the clinic, well, they may be responsible for some of this data. So that's important to know kind of the differentiation between where is the data living within our system? Is it more on the clinic side, or are we having to rely on the hospital to run and generate reports to then send back to the clinic to be able to give them some of these operational metrics that we had decided that we would like to track? The next question that we think about is that what metrics are critical for clinic success? So again, this is kind of the point that I mentioned of, you don't necessarily have to have every single one of these key performance indicators tracked, but it is important to say, hey, we have initiatives currently underway with wellness visits. Okay, well, if we have an initiative related to wellness visits, we probably need to be tracking and trending that over time. So that's a metric that would be critical for our success for a specific project, or just overall health of the organization. And then kind of like I mentioned before, but who is responsible for the specific reports and metrics is extremely important. A lot of times we assign an owner, a specific individual, and they're just so used to running a report, and then something happens, that person either moves into a new position, they leave the organization, and now we're stuck. And that person has been the one that's generating these reports, getting the data together for us, and now we don't have anybody that can kind of fill that gap. So it's extremely important when we are setting up kind of this structure of key performance indicator and operational efficiency, that we're making sure that we're setting it in a foundational way to the organization so that we're not just putting all of this on a specific individual, so that we, in the times that we have individuals that leave the organization or move on to different roles, we can fill that gap, and we're not going to have all of a sudden 2 months where we have no reporting capabilities because we don't have somebody to backfill to be able to report on specific metrics that we're already tracking. And below, this is not necessarily anything specific, but just an idea of what a dashboard could look like. You could take specific categories. So here you'll kind of see they have aging AR, charge and payments by year and month, looking at claim denials, and then charge and payments by insurer. So if these are the 4 or 5 items that we say, hey, these are the top priorities that we need to keep an eye on, then that would be something that ultimately kind of find its way to a practice management dashboard. And then that way you have it, it's in one location, you know where to access it, you know kind of the process for how that data is getting updated. And then ultimately you're tracking and trending it over time so you can make changes and make decisions based on how that data trends over a period of time. So the next thing we're going to do is kind of get into actual provider production. So when we come into an organization, we typically ask for a year of CPT data. This helps us understand what exactly types of patients are we seeing. So do we have a family practice physician, and we'll kind of get into in a second, that is seeing, you know, a lower acuity of patients, but they have a lot higher volume? Or is it somebody that has higher acuity patients with multiple comorbidities that's having to spend more time with these individuals? So in order for us, because we're not doing a full coding and documentation review, we're simply getting a year's worth of data and then kind of putting it through this benchmarking analysis. This helps us to get an idea of, okay, what types of patients are these individuals seeing, and exactly what production is coming out of each one of these clinic locations and each one of these providers. So I'm just going to kind of familiarize you to what the graph that you're looking at is. So over here, you'll notice you have a provider name, a specific specialty, and then kind of an FTE status. So this historic level here is ultimately the production that came off of the year's worth of data. So we're looking at evaluation and management chapter codes. So this is kind of the 99201 through the 99499s. So this is not just the new and existing patient visits, but this kind of grabs all evaluation and management chapter codes. So that's kind of what the historical level will show us here. It's extremely important to understand the FTE status for each one of your providers. A lot of times we have a provider that has administrative functions, so they may only be a 0.6 FTE status and a 0.4 administrative. It's extremely important to understand where their clinical FTE status stands, because that's what ultimately plays into the benchmarking. So the 2 things that are really important to understand is that specialty is going to actually pull in who are we measuring ourselves against. You'll notice that this is kind of looking at, if this was a client that's within the southern region, we're going to look nationally, and then we're going to look locally within that specific region. So did we get the specialty as close as possible? What is our FTE status? And then ultimately, what was the production that came from each one of these individuals? So the historical percentile ranking is essentially taking, hey, you know, I'm looking at this first individual within pediatrics. We had 3,500 encounters. What did that measure up against the rest of the country and the southern region? So you'll notice kind of this far side is the market data that comes off of that. So we include this down here in the footnotes. So this is the MGMA Physician Compensation and Production Survey. So this 3,500 falls within that kind of 75th to 90th percentile, which is that 78th percentile here. So this just gives us a good understanding of, okay, this makes sense. We know that we have high producing providers. They're a little bit higher, but this is not going to be the end all be all. So we do this kind of as a first step. And then we actually get into what was the RVU production that came off of the CPT data that we received. This is more of a spot check just to make sure that, you know, if we talk with the organization, we have a chance to speak with the provider, they say, you know, I see 30 to 40 patients a day, and then all of a sudden they only had 1,000 encounters that came across. That instantly kind of tells us, hey, we may be missing some data, or there may be something that's happening within the system that we're not getting credit for, or is not being captured through our EHR. So that kind of frames up what we're looking at when we're actually diving into physician production related to encounters specifically. So this next graph is going to look the exact same. It's just going to be RVU production. So Again, we're going to have the provider here. We're going to identify a specific specialty. So you'll notice on this slide, I adjusted some of the FTE status. So we kept one as a 1.0, and then the rest, say these individuals have additional functions. It's an RHC. So one of them is kind of serving as the director of the RHC. And so that means that not all their time is going to be clinical. So that's something, again, we have to keep in mind when we're looking at what ultimately is provider production. And how exactly does that stack up? And we wanted to get it as close as possible, as one-to-one as we can. And that's why it's so important to have an adjusted FTE status to pull in kind of what exactly does that look like for a specific provider and specialty within a region. So again, same set of data, except this time we have assigned all of the worked RVU production for all the CPT codes that came across for a specific year. You'll notice here that these individuals are above the 90th percentile. No issue there. We see this kind of often when we have very high producing clinics. We'll have a lot of individuals that are coming in above that 90th percentile. And all that's saying is that not only potentially are you seeing a lot of patients, but you're also seeing patients that skew appropriately with kind of the acuity level that you would expect, which we'll get into more so with the EMR distributions. And again, feel free if you have any questions, if something doesn't make sense, to just type a question in the chat box, and I'll try to monitor that and track it over the rest of the presentation, and we can address it hopefully as we're looking at something. But again, you'll notice that this adjusts. So this is extremely important just to understand not only where are our providers producing and how are they performing, but this can also kind of drive back to what are our providers' contracts? Are we measuring them off of specific encounters and how many patients are seeing, or is it really based on RVU production? We've had examples where you have an organization that you have two, let's say, family practice providers. One of them is extremely high producing, sees lower acuity patients, so they see 20 to 30 additional patients a day. Well, that's why we look at both encounter production and RVU production, because just the counter to that is that, let's say the other provider is seeing a lot less patients per day, higher acuity, so they're the higher level visits, so the 99214s, potentially 99215s, if they get to that point. We want to make sure that we're capturing the actual production that's coming off of these visits. And ultimately, all of this drives into, is there anything that we need to be doing on our end to make sure that, are we offering additional training? Do the providers have what they need to be able to take care of the patients? Because if you're spending the time and effort with a patient, we want to make sure you're getting credit for that specific visit. So now we're going to kind of take a jump into the E&M distributions and really the reason behind it. So this is just a general E&M distribution that you all should be familiar with to kind of familiarize you with how the data is set up. This black line or blue line, however it's showing up, is the CMS rate. So it's essentially saying that based on the data that came across for CMS, looking at a specific specialty, note that this is also related to, this is a MD. We can get it down to the NP/PA level as well. And it's important to be able to note that in the data or when we're looking at specific data sets that we have is as accurate as possible for benchmarking purposes. So here you'll notice that it's pretty much in line with kind of from the new patient encounter perspective. So we had 119 that came through on the 99203s, and then we had 40 on the 99204. So that's somewhat in line with kind of what's expected for a family medicine provider seeing new patients in a clinic. Then we kind of look at the established patient encounters. So this individual had 1,600 encounters that came through on existing patient visits that were 99213s. But you'll notice that there's a little more of a gap here for the 99214. So this is not necessarily saying there's anything wrong. It's not necessarily saying this provider is undercoding. It just lets us know, okay, hey, maybe we need to dig in a little bit deeper and look at exactly what activities this provider has going on within their practice. So do they truly have lower acuity patients and it makes sense for all of them to be 213s, or are they just kind of blanket coding and slapping the same, using a template and kind of filling in the information and getting it to where every single time a patient comes in, they're saying, yep, got these 3 or 4 items. Okay, that makes it a 99213. And to be safe, I'm just going to leave it as a 99213. So again, that kind of gets back to the point. If you're spending the time and effort with a patient, we want to make sure that you all are, and your providers are getting credit for the work that is being done. So this is again, this is family medicine. You'll notice the trends kind of where the new patient counters are more so to the middle with the 99203s. And then it does scale up a little bit, which is to be expected when you have existing patients. You start to learn about comorbidities, other items that you have to work on with these individuals. So you would expect it to kind of scale a little higher up on those existing patient visits. So the next one we're going to look at is more so related to a specialist. And this is a pediatrician. So you'll notice that for the new patient encounters, which to be expected, the majority of them are 99204s. You're going to have to spend a little bit more time with these. Anytime you have a specialist, you would expect that there's a reason that they got referred to the specialist. Therefore, they probably have something going on that's outside of that normal kind of family practice, family medicine purview. Again, this one I think is a good example just to show of what exactly it looks like. So you had a few on those new patient visits that were a little bit lower, which is completely fine. And then again, with the established patient encounters, typically within specialties, we see it skew higher. So those 99214s are definitely to be expected with established patients on any specialty, not necessarily just pediatrics. So I'll kind of, now that we've gone through some of the KPIs and some of the data, we try to keep all of that in mind when we're going into an organization to just look at the entire revenue cycle process. So here we'll kind of start with that provider productivity. So the first thing, similar to what we looked at the KPIs, is what capabilities does our EHR have? So if we realize that, hey, we're going to set these goals for our providers and we expect them to see 40 patients a day and do that every single day for the year, that may be a realistic expectation. If you have a great system, everything's easy, documentation is not taking them a ton of time, but that may not be a reality if they're having a free text for every single encounter. The system may be a little clunky. They're having to go other areas within the system to access information. So those are all things that we kind of need to keep in mind when we're looking at provider productivity. And then we also have to look at the community. So what community are we serving? What is the patient population around our area? What does the patient demographic look like? Are we kind of serving an older community? Is it a younger population? All things that we have to keep in mind when we're looking at provider productivity and kind of what ultimately is playing into the production that's coming off of each one of our individual specialists or providers within our system. The next question that we like to think about is that, are we utilizing any additional software or programs? So I think the easiest one to think about here is, are we utilizing dictation systems? Are we using a third party that's actually doing the coding and documentation? Are we doing kind of internal reviews? And do we have somebody on our staff that's doing some of these things? Or is it something that's truly living outside of our organization with somebody else? And then the next question, kind of, do our providers have contract incentives for volumes and production? So this is, again, why we kind of look at both those encounters and the work RVU production that comes off of it. A lot of times, depending upon when a provider came in an organization, their contract may have very different terms from somebody else in a same position that has been there for a little bit longer. And that's completely okay. It's not saying that you have to have every single one of your provider contracts aligned, but it is important to know what types of patients are they going to be seeing, what is their work RVU production going to be, do they need to be measured more often in encounter level, or should we try to get it to that work RVU level so we can see the true production coming off of each one of these patient encounters. And I would just say down here, so again, the important for the E&M distribution is to be able to kind of see how our providers are performing, track and trend anything over time. And this should allow us to say, if we have a provider that's only coding a 99202 and a 99212, maybe they don't feel comfortable coding above and they're just playing it safe and they're going to select that lower code every time. Maybe that's something that now the organization needs to step in, set up a training program and make sure that they have the right tools and access to everything that they need to be able to do their job appropriately and give them the confidence to take care of the patients and get credit for the work that they are doing. Things that you can think about to consider when you have an individual that's falling kind of below your production expectations or outside of those normal range is that what exactly does their schedule look like? So we're kind of dive into how can you manipulate the schedule or change the schedule around to better meet the needs of your providers and your organization. Do we have protocols for chronic care patients? Are we making sure that we're getting these people into the right programs, knowing that they have multiple comorbidities or may need a little bit more time and effort? And then we got to look at things like clinic staffing and support. Do the providers have the support and staff that we need within the clinic? And this is not necessarily saying that this stops when we're thinking about it from a provider perspective. We have to also think about this for the nursing staff, for the non-clinical staff, the support staff. Do they have what they need to be able to kind of support the organization and the clinic as a whole to make sure that they can do their job appropriately and they're not spending all this additional time with these non-value added activities ultimately that do not offer any benefit to the patient. So that's kind of the provider productivity and the things that we think about coming off of the data and why we dive a little bit deeper into our data analysis. So the next item, again, we're just kind of going to start at the beginning of the revenue cycle process. So the first thing is scheduling. When we're looking at the appointment types and times, it's important to understand a lot of times within organizations that not everybody wants a blanket schedule. So we see it at times that certain providers and staff have been working together for a long time, so they understand the provider preference. They know when to schedule what types of patients. That works well, and that's great. But the reality is that especially, and it became more so now kind of through COVID, is that at times we have staff that are out, that are having to cover in different areas. And so the more that we can outline some of these items, the better we are setting our team and our other staff up for success, because if they are having to cover and fill in for somebody else, they can look at something like the schedule on the right side and say, oh, I know exactly where I need to try to drop specific patient types. I know that, if I have an existing patient and it's a Thursday, I'm going to try to drop into one of these slots. Not saying that that's always going to work or this is always going to be 100% achievable, but this does kind of set you up for, are we sticking to our schedule? Are we dropping the patients in a time and slots that make sense so that we're not stacking a bunch of new patients or procedures that are going to ultimately at the beginning of the day get us off to a slow start, and now we're 30 minutes behind for the rest of the day trying to play catch up. So things like outlining a schedule for a provider can be beneficial. And again, it doesn't have to be anything as detailed as what you're seeing on the right side. It could just be, ideally we were seeing all existing and new patients, and then we stack procedures on Tuesday and Thursday, or we have them all Friday morning. Just things that make kind of that clinical efficiency and workflow work a little bit better. These are all things to keep in mind, kind of like I mentioned, the clinical workflow. So what is best for the patient? We ultimately don't want the patients having to wait a long time when they're coming in for an appointment or a visit. So if we're able to stack the right patients at the right times, that helps us make sure that we're kind of getting people through the system as efficiently as possible and not spending time in kind of these non-value added activities. Again, kind of keeping in mind, it's not necessarily, obviously the ultimate goal is to take care of the patient, but we also have to look out for our staff. So making sure that they have the right tools and access to the right programs, and that they have kind of, again, the support from us as an organization and a leadership team to be able to do the things that they need to be able to do. So two more things kind of keep in mind. Provider preference. Obviously, when you're building a schedule, you want to make it to meet the needs of your provider. At times, you may not be able to, like I've mentioned, kind of fill in exactly what we've outlined on the right side, but this at least gives us an idea of where we need to be dropping specific types of patients, so that if I have any questions, if I'm filling in for somebody else, I can use this as a guide, and I'm not having to every single time I have someone call in, take some time, go back, talk to the provider, make sure they're good for me to schedule it in a specific time slot. And then now I've spent 5 or 10 extra minutes. And if I'm having to do that over and over again, that can quickly become extremely time consuming. And now that's pulling me away from, maybe if I'm a registration staff and I'm not having, now if I'm back talking to the provider, I can't check people in, I can't get things signed, I can't get consent signed off and everything ready. And so now we're kind of causing delays because I'm having to step away just because I was unsure of what our provider preference is for scheduling. And then the other idea to keep in mind here is that kind of the scheduling process as a whole. Are we scheduling appointments in advance? Have we set a culture of walk-ins? We've seen this before where we have providers that prefer for walk-ins, and that's great, but that can cause a little bit of confusion at times. And if we have the opportunity, if we have a patient in the clinic and we know they're going to need to be back in 3 to 6 months, we might as well go ahead and get them scheduled so we don't have to worry about it. And when that time comes, if we need to adjust it or schedule on for a different date, then we can absolutely do that. But it's beneficial to have them scheduled, have them on appointment, and kind of build that into our process that we're scheduling patients in advance. And then that helps us do some more of those revenue cycle functions like collect insurance, get insurance verification, things done prior to the patient arriving at the facility, which kind of speeds up the process. And we're now having things that are already ready to go instead of having the day of to get verification or change in insurance or talk to the patient for specific items. So another thing to keep in mind is that a lot of times patient portals are beneficial kind of in this spectrum. If the patient is now scheduled, we have the capability in a lot of patient portals to go in and sign consent forms. If they have questions, you can message the provider. So a lot of that work, doing it in advance, can be extremely beneficial for kickstarting kind of on the right foot. So the next thing we're going to look at is, okay, we scheduled the patient and now we're getting to the patient check-in. So what information had been collected prior to patient arrival? Did we gather insurance? Did we get updated demographic information? Have we stored that in our system? And does our registration staff have easy access to the information that they need? So if we got insurance, has it been verified? So just because we collected it doesn't mean we're necessarily already verifying it prior to the visit. This is where things like batch eligibility can be extremely beneficial. So a lot of organizations have a process, the day before you're going ahead and kind of verifying insurance, seeing where you need to spend a little more time, who you need to potentially call and speak with. You may not have the capabilities within your EHR, and that's totally fine. It's all kind of building a process out that works best for you. The next item I kind of touched on a little bit, but where are we spending our time? So where's our staff spending our time? Is it a value-added process? Is it a non-value-added but essential process? So unfortunately, we're going to have to get people to sign consent forms. We're going to have to get people to fill out other information. Those are not necessarily directly value-added because it's not related to the patient care, but it's essential to the function that we are doing as an organization, as a clinic. And then we got to look at the non-value-added, non-essential. So this would be something similar to, I like I'd said with the scheduling, if I'm having to kind of step away and go ask a question to somebody in the back just to get an answer related to should I schedule or related to, a specific patient visit, that's something that potentially we need to evaluate that process and see if we can put something in place or potentially remove a step altogether. And again, it can be as easy as just providing something to our staff to make sure that they have the right access and the right information they need so that they're not having to have these kind of non-value-added, non-essential steps built into their process. And then ultimately, kind of the point below that is it's extremely important to have uniform and efficient check-in and registration processes across your organization. We don't want to set a standard. If you go to one clinic, and we'll kind of get on this with the patient collections, but and we see this happen all the time, unfortunately, that certain clinics within certain organizations in the community, the word spreads that, hey, I went in one time, they didn't ask me for my point of service collections. And so there's now an expectation that if I go to that clinic, I'm just not going to have to pay. So the more that we can outline these processes and build strong processes and kind of trickle these out throughout our organization, then it sets an expectation for the patients. They know what's going to occur when they come in. They know the information they're going to have to provide. They know an expectation to pay. And then that just kind of keeps it seamless, not only through the clinics, but also on the hospital side as well. If you set these expectations on the clinic side, it can be beneficial on how they approach kind of their care within the hospital. And then the registration activity benchmarking. So this can be as simple as saying, hey, we're going to look at 10 different metrics related to registration activity. Did we get insurance? Did we get their demographic information? And if we do this for each one of our registration staff and kind of trend it over time, we can see, hey, maybe similar to the providers, do we need some additional training related to this specific individual in this specific area? The reason that it's so important to have this data and trend it over time is that when we do these trainings, we don't want to just say, hey, we assume everybody's performing on the same level, everybody has the same issues, everybody has the same concerns, and then just do blanket training, because that's not always going to be as beneficial as doing tailored training related to areas that individuals may be struggling with kind of within their process and within the organization. So the next area is we're going to look at kind of patient collection. So are we tracking different types of collections? Do we have the ability to identify a collection as a point of service collection within our system? If not, how are we identifying if something came kind of point of service versus later from an insurance company? And all of that kind of plays into what data do we have? How are we driving? If we have an initiative related to point of service collections, but we can't actually identify what was a point of service payment, then it's going to be extremely difficult to, one, set a goal of where we would like to get, and then track your progress to that specific goal. So these kind of the second and third points are really hand in hand. So what exactly is our process for point of service collections? And this can be as simple as, hey, we have a standard script that we give to all of our staff on how they ask these questions, how they ask for collections. And then that can make staff feel a little more comfortable. They know exactly what the expectation is. Again, we're building that expectation for the patient. If they come in, they get asked the same question in the same manner over and over again. It slowly builds up an expectation that if I go into the clinic, this is what they're going to ask. This is the information they expect. They expect me to pay. And again, the scripting and kind of prompts are something as simple as, how are we asking for collections? You know, hey, are you going to pay today versus how would you like to pay? Do you have a cash or card? Things as simple as that can make a big difference in how our patients are perceiving their liability and expectation to pay. And then the bottom point, again, just kind of it's very critical to understand your capabilities and tailor these processes to meet the needs of the organization. All of the information that we're covering can be null and void if you don't have the system capabilities. So it's important to understand where are our limitations. Do we have to set up separate processes and build separate processes and kind of within our organization to meet what our goal is? If we don't have access to data, it's very hard to then have a goal of improving a specific metric if we can't see it and track it over time. So now that we have the patient's been registered, they're here, everything's cleared, we got them, kind of had a point of service collection, and now they're here for their actual visit. So the reason that we like to dive into really the charge capture and coding is it can give us a good understanding of where do we need to spend our time and effort with our providers. A lot of times we have providers that are very comfortable with coding and documentation. They just may not be comfortable with the system they're using. So is that causing delays from more of a system perspective, or we just end up missing information in specific encounters, and that's why they're coding a little bit lower because they didn't know where something was within the system, or they didn't have the time. They're having a free text entry. So it's important to kind of look at, do we have a good understanding of those trends, the limitations, and the needs of each individual provider? Again, we don't want to have blanket statement that all providers need training or have gaps in a specific area. We want to be able to tailor it to providers because it's hard enough to get providers away from patient care. We want to make sure that we're not pulling them into a training that's not going to be beneficial to how they're actually meeting the needs of the patient. These items, kind of the provider responsibility versus nurse responsibility versus other staff and vendor responsibility, things to keep in mind. So are there true gaps that exist within kind of our process of taking care of patients or coding and documentation? And then ultimately, who's responsible? So if we say that we're going to kind of adjust a process, but in reality, that process lives with an outside vendor or a third party, it's going to be very difficult for us to do that as an organization because we do not have ultimately control over what's going on. So yes, we are the organization, we are the one that has the contract with the third party, but if they're the ones that are doing all the documentation, if you're using a third party like a Dragon, it may not make sense to look at some of these items if we have other processes that kind of live with outside the responsibility of just the provider or the nurse or the other support staff that's within the clinic. And then really the last point, I've touched on it a couple of times, but it's extremely important to have a good understanding of kind of the coding and documentation, not only to just make sure that everything's up to speed, but again, to understand where the gaps may exist within specific providers. A lot of times, a lot of organizations, you have different backgrounds of providers. Everybody went to a different school. Everybody had training in different areas, different ages when they came out of training and what they had access to in their training. So the more that we can kind of tailor and gather information specific to one individual or one provider, that allows us to better make decisions related to how are we going to kind of spend our time and effort or resources. If we know we're extremely tight and strapped on the kind of clinic internal side, we want to make sure that we have the right resources and put those resources where they're going to make the most bang for the buck for the clinic. So these are kind of the last few areas. So when we're looking at billing, so the provider's now seen a patient, the counter has been coded. Do we have in-house billing or is it a third party that's responsible for it? A lot of this kind of plays into where's our data, who's responsible for managing that data. If you have a third party, a lot of times these third parties have a lot of good reporting. They can be set up within your system. Again, it's a matter of having those conversations and saying, hey, you're responsible for some of these billing activities. You're the one that's seeing the claims go out. You have good kind of purview into the denials that are coming back in, things of that nature. So where exactly are we billing from within the clinic, and does that differ from the hospital? So again, I kind of mentioned at the beginning of the presentation, are we billing out of the clinic, or is that kind of function living within the hospital? It's important to understand those subtleties. Depending upon the organization, we've seen it where one clinic, the case is they're billing out of the clinic, the other clinic is billing out of the hospital, or it's running through a department of the hospital. Very different process, very different goal there, exactly what we're going to have to kind of work on. They may be using different systems. All of that is extremely important to understand of kind of who's responsible for what. And then this down here is just kind of what is the process for finalizing an encounter. So we just want to make sure that, you know, as we have seen a patient, we have coding and documentation that's going into an encounter. Who is doing that review prior to billing? If there is something that's missing, what does that feedback loop look like? Are we doing that kind of within our EHR? Do we have the ability to notify a provider? Do we have a work queue that they can say, hey, I need to go back and look at all these encounters? And then ultimately, if they do make those adjustments, how are they making the updates? And then how are they kind of spinning that, again, full circle to go back out and say, hey, I've made the adjustments. Everything's good for billing. All things that we have to kind of keep in mind. What exactly does our process look like from start to finish? But then also, if we have an error that kind of pops up within that system, how exactly are we getting kind of that feedback to the right individual? Denials, extremely important. Again, all of this kind of plays into coding and documentation. So who is actively managing these denials, and where is that information located? So do we have access to it in the system? Who's getting notified of denials, and are we passing that information back to providers? So similar to kind of the coding and documentation audits, it's extremely important, and denials can tell us a lot of information related to specific coding and documentation trend for providers. So if we're getting denials over and over again for a specific issue, it's going to be extremely important to be able to kind of mitigate whatever's happening, address those concerns. And again, the ability to get this down to a provider specific level allows you to tailor that training or the intervention for that specific individual, instead of just doing blanket, hey, we're going to look at denials and just assume that everybody's kind of performing at a set standard and then go off of that and just do a blanket training related to it. It's extremely important, especially for denials, to stay on top of it. So whether that's you're looking at it every week, you're looking at it bi-weekly or monthly, this is something that you don't necessarily want to go 6 months without looking at, because if you get 6 months down the road and realize that you've now had 500 denials for the same reason, instead of looking at it on a weekly basis, you could address this kind of within the first week as you see it start to trend up and say, hey, maybe we need to kind of step in and put something in place, or look at why are we getting these denials all of a sudden. This can happen from insurance. You can have credentialing denials. You can have administrative denials, things that are not necessarily your fault, but you need to be aware of them so that if they are starting to bubble up, you can address the issue before it gets, 3-6 months down the road. And now we're dealing with a ton of denials, and then somebody has to spend the time to getting those resubmitted. And then the accounts receivable is just understanding, where's our AR sitting? Are we able to look at it by age and group? Typically, you'll see the AR over 90 days is the one I touched on the KPIs. And then it's important to understand the differentiation between collectible versus bad debt. So a lot of times when we're looking at organizations, we see a very high AR over 180 days. A lot of times that's not going to be collected. So it can be important to understand of where exactly in the AR are we sitting. So are we sitting kind of further out, those 90 plus, 180 plus days? Is that actually going to be collectible, or do we kind of need to do an AR cleanup project and write that off as bad debt, so we understand when we're looking at our AR, what is truly collectible and what are we actively working at? So again, if there's any questions that come, so this is kind of where Steve is going to pick up, but feel free to put the questions. I'll continue to monitor the chat, and then we'll have question time kind of at the end as well.
Sounds good. Thank you, Carson. And as you mentioned, there's a couple slides here that are really just related to optimizing the reimbursement and operations that are happening within that rural health clinic space. So, take Carson's information that he had there as kind of a baseline for any physician practice. And then there's some specific things that rural health clinics can do to maximize the reimbursement that they're getting, as well as the operations of their clinics. And I want to give just a very high level overview. Everyone's probably aware at this point of the new regulations related to RHC reimbursement. We know that if you're a new RHC, whether you're provider-based, less than 50 beds, provider-based, more than 50 beds, freestanding, doesn't matter. If you're a new rural health clinic, you're going to fall under these caps. And so we know strategically we need to have our cost per visit fall somewhere above these caps so that we're maximizing that reimbursement opportunity. For example, if we're in 2023, we don't want our cost per visit to come in at $120, knowing that that's going to decrease our reimbursement by $6 per visit per year. So we obviously just want to keep that in mind as we go through for any of our new rural health clinics. Go ahead to the next slide, Carson. And here, as we start to look at grandfathered rates, again, the strategy is the same in that we want to make sure that we stay above our potential cap rates, but we also understand that our cap rates as a grandfathered RHC are only going to grow by Medicare Economic Index each year, somewhere between probably 1% and 3%. So it's not the $13 per year where we've got a known figure we're trying to stay above if we're a new rural health clinic. We just want to make sure that our cost per visit figure is rising 1% to 3%, ideally 3% to 4% above where we were the previous year, so that we can, again, make sure that we maximize our reimbursement under that structure. If anybody has any questions, related to this, certainly don't hesitate to reach out after the fact, but I want to be sensitive to time constraints and get to some of these other points. Carson, we can go ahead to the next slide here, and next one as well, please. Go ahead forward one more. There we go. So as we look at our maximization strategies, and this is for any rural health clinic, there's 3 primary ones that organizations have found very effective. And I want to be very clear that the goal here is not strictly to increase our reimbursement. We certainly want to do that. It keeps us viable as an organization. But we also want to make sure that we're expanding the care that's available to our patients. So as we look at things like no-show reduction, we know that if a patient were to miss a stay, or a visit, I should say, and let's say something could have been identified in that visit, there's an opportunity that down the road, that thing that they were going to come in for could be much more serious. We could have infection. We could have a number of different things happen. So we want to make sure that we can get them in for the visits they're scheduled for, take care of whatever issues that they have. In addition, if we have 0 revenue for our no-shows, and we can get our all-inclusive rate of, let's say, $126 for our Medicare Medicaid patients, obviously, there's a reimbursement impact there as well. Now, again, we have to make sure that our front desk is doing what they need to do in terms of appointment reminders and getting a correct patient contact information, all those things to make sure that we can hold those visits when they're scheduled. Medicaid conversion is another big factor. So for those of us that may have a high self-pay patient mix, is there an opportunity to convert any of those to Medicaid? Let's say we get $10 per patient on average for our self-pay patients. Again, compare that to the $126 for an all-inclusive rate, and all of a sudden it's a much more financially beneficial visit for us. At the same time, from a patient-facing standpoint, if we can qualify them for Medicaid, think about the additional services they have available to them now, where maybe they didn't before. Or the ability for that to be covered by an insurance, and maybe that breaks down a barrier to coming in for visits that they may not have done before. I've got, what I think may be strep, but I don't want to pay for an office visit, so I'm just going to ride this thing out. Well, if we can get them on Medicaid coverage, not only do we get the all-inclusive rate, more importantly, we get that patient in and we break down that barrier of cost of care so that they can potentially come in, be seen, and then again, get those benefits of the additional coverage options. And then annual wellness visits. We know that these are reimbursed at 100% for our rural health clinics. So how good are we at making sure that we have our patients scheduled for these visits every year? Do we have mailers that go out to our patients? Do we have phone calls? Do we have system reports that can let us know who's due for an annual wellness visit? When was their last day? To make sure that they don't report on day 362, knowing that that's not going to be covered. Making sure that we get them scheduled on the right date and all of that. And again, that's the financial aspect of things. But if we look at it from the patient care perspective, we get that patient into our clinic. We have a chance to put our hands on that patient, get a sense for where everything's standing right now. Do we have any concerns? Do we have anything that we think we need to monitor or address as we go on down the road? All those things are critical to quality patient care. Next slide, please. So a couple Washington updates I want to make sure that we cover here in the last couple minutes. These items were all included in the 2023 Omnibus package. So in one way or another, these are moving forward. The biggest two, all of them are big, but the two related to providers are these marriage and family therapists and mental health counselors that are now going to be eligible providers in a rural health clinic effective January 1st, 2024. Now, the problem we have here, and I could get on a soapbox for an hour and a half if I wanted to on this, but from CMS's perspective, mental health services are still considered specialty services. And so as we look at that 51% primary care threshold number, we can't have too many mental health services that are provided that are going to jeopardize our RHC status because we're providing primarily specialty services as opposed to primary care. I'm hopeful that moves like this indicate that CMS is going to potentially look to have mental health services included as primary care services, but we're waiting to see where all that kind of plays out and how that'll be determined down the road. Intensive outpatient services, that treatment category is going to be created effective January 21, 2024. We have to see some additional details that are going to come out in the next Medicare physician fee schedule to see what exactly is going to be entailed in those programs, what's allowed, what isn't, participation requirements, all those items. And then huge benefit for a lot of folks is the Medicare telehealth flexibilities. We know that the PHE is going to come to an end, probably here in the next couple months. The good news is previously, telehealth flexibilities were set to expire the 152nd day after that ends. Now that's going to be extended out all the way through December 31st of 24, regardless of when the PHE ends. So good news there. Still not going to be reimbursed at the all-inclusive rate. Still hoping some of that comes through, but we'll wait to see where that lands in the future. Next slide, please. Last thing I want to cover here is the RHC Burden Reduction Act. This is something that is in process. We don't know where it's going to go, but it was entered into the Senate by the senators listed here. And there's 5 very important things for RHCs to kind of keep an eye on. Modernizing the physician supervision requirements. So can we have a little bit of relaxation there? Removing the requirements to directly provide lab services if they can provide prompt access elsewhere. So if you're in a hospital's campus, can the patient just go over there and can I not have to have all this lab equipment on site and have to worry about maintaining that and all those things. May allow RHCs to employ or contract with non-physician providers. As you know, currently, you have to employ at least one, so this could be some reduction and some burden there. Location eligibility issues. Anybody who has been watching, discussion boards and everything else knows that the Census Bureau had changed some of their methodology to where they no longer have a rural, urban. They've just changed some of their verbiage, which has actually impacted the eligibility of some locations. And so the hope is we're able to do a population base as opposed to tying back to Census Bureau definitions to where any county that has less than 50,000 residents would qualify as rural and be able to have a rural health clinic. And then lastly, increasing the amount of behavioral health services that can be provided in the RHC if it's located in mental health HPSA. And again, this is one we're watching very closely to see if this allows mental health services to be considered those primary care services that I and a number of others believe they truly should. And especially for those that are in that mental health HPSA, which most of the country is. So a few things that are just going to be very interesting to watch here over the next number of months as we start to look through towards the next federal fiscal years. But with that, I know that we're right up at our noon time for our stop. I do want to thank everybody for their attendance today. If anybody has any questions, Ashley, I see your question there. I will look into that specific to FQHCs and get a sense for, what those look like. I do believe they're going to be similar, if not the same. They usually follow the same track, but let me verify that to make sure. And I will get an email back out to you to confirm that information. With that, Latrell, I'll kick it back to you.
Thank you so much, Steve and Carson. If everyone would please just take a moment to complete the post polling. There's 4 questions, so we can just get a gauge on how you feel about today's webinar. I am confident, or how you feel in my understanding of how to compare my organization's key performance indicators. provide a productivity benchmarking and current procedure terminology code distribution to industry benchmarks. I am blank in my understanding of best practices to enhance back-end revenue cycle performance. I am blank in my understanding of best practices related to rural health clinic operations and reimbursement. And I am blank that I would apply the knowledge gained from today's educational training measure by organizations' internal performance related to revenue cycle management and physician management. Okay, and the results are on the screen. Again, thank you, Steve and Carson, for your time today. We really appreciate it. And I hope everyone who attended today, I hope you all have a great afternoon. Thank you.